All right, hello everyone. It's nice to see everyone. Let's get the webinar started. Are our subtitles working? Yes.
Here's something I found on the web.
Alexa, stop. That was very funny. Okay. So it's very nice to meet everyone. I am Sam Crane. I am the legal director at the Autistic Self-Advocacy Network. And I am pleased to bring for this webinar some great panelists. We have Natalie Chin. Natalie Chin is an associate professor of law at the City University of New York and the co-director of the Disability and Aging Justice Clinic. The DAJC represents low-income New Yorkers in a range of issues, including prisoners' rights, securing due process protections in areas that include guardianship, alternatives to guardianship, and disability-based discrimination. Before joining CUNY's faculty, Professor Chin was an assistant professor of clinical law and faculty director at the Disability and Civil Rights Clinic at the Brooklyn Law School, where she created and developed the first law school clinic that advocates for adults with intellectual and developmental disabilities. Professor Chin has the particular experience of working on responses to medical discrimination during the COVID-19 pandemic, including co-authoring the sort of an intersectional guide to crisis standards of care. We also have Shira Wakschlag at the legal director, Shira, legal director at the ARC. Shira has, as legal director of the ARC, been extremely involved in monitoring and responding to concerns about medical discrimination during the COVID-19 pandemic, including discriminatory crisis standards of care and medical discrimination in other forms, such as denial of communication and denial of support in hospitals. Shira manages the ARC's legal team and has been involved in many other really exciting disability rights advocacy projects as well. So I am really excited to have them both here today, and we will move on to the next item on our agenda, which is some background on medical discrimination before the COVID-19 pandemic and how it set the stage for issues during the pandemic. So I will turn to Natalie. Natalie, you are on mute.
I'm sorry. Can everybody see my screen?
Yes.
Okay, great. All right, everyone. Well, thank you, ASAN and Sam, for inviting me to talk about this. As Sam mentioned, I'm going to spend maybe 15 or so minutes talking about, a little bit of history of medical discrimination way before COVID, and kind of, tie together some of the foundation for why we even got here in the first place, and why we even needed to create an intersectional guidance for healthcare professionals around standards of care during the COVID pandemic. And so the first thing I want to talk about is first, this is a picture, I'm on the second slide, of Audre Lorde. She's a Black woman with a short afro and some kind of oval shaped glasses. And it's a quote that says, "There's no such thing as a single issue struggle because we do not live single issue lives." So I think that this quote is really important for this discussion, because when COVID first sort of erupted in its intense form around March of 2020, when we read about COVID, we really just read about either race. We didn't really read about the intersections of race and disability and poverty and all of these other things. And I think that that really got us in trouble. And as we've learned to better understand the impact of systemic racism and ableism on those who are most impacted by COVID, that narrative is changing. But the single issue struggle has, I think, something that really sort of encompassed COVID narrative at the very beginning that's really changing. So I'd like to start with this quote. So I thought before we jump in, it might be helpful to, since we're going to be talking about the crisis standards of care, what does that actually mean? So the crisis standards of care that Sam mentioned that I helped draft are plans that provide guidance about the factors that consider who gets priority when determining whether there's enough medical resources to distribute. So just to correct, I didn't write crisis standards of care, but the intersectional document that we created that relates to standards of care I helped draft. And so really it's guidance. And what does that mean? And it's very discretionary. So doctors and other healthcare providers don't have, they don't have to act, but they're guided, and it's voluntary and usually non-binding for the most part. And what that means is medical professionals can act, in clear violation of state and federal anti-discrimination laws when deciding who gets priority for medical resources. And this became a real issue during COVID because there was a shortage of, medical rationing was an issue when we were at the height of the pandemic. And we see now that in certain cities and states, we're sort of revisiting this again because of the Delta variant. So the issue of medical rationing really puts this discretion in states and hospitals about who can make decisions on scarce medical resources and who should and should not have these resources. So that's what we're talking about when we're talking about crisis standards of care. And, when the pandemic sort of, as I said, I'm sort of naming this as March, April 2020, when things kind of exploded, medical rationing discussions, all these advocacy groups rushed to challenge the medical rationing policies. There are several states that really, really got it wrong. And Shira, I'm sure, is going to sort of go into this in more detail. I just wanted to give two examples to kind of put it in context. Like, what are we talking about with crisis standards of care? So two states I'd like to highlight as bad actors is Alabama. And the Alabama language around COVID, when they did their medical rationing policies, specifically said that those with, and this is quoting from the policy at that time, those with severe or profound mental retardation, moderate to severe dementia, and severe traumatic brain injury essentially would not be offered mechanical ventilators. And you can understand how the arbitrariness of the medical rationing policies, it just excluded whole categories of people. And another bad actor amongst many was Tennessee. And Tennessee's medical rationing policy said, you know what, state, this is the deal. You don't have to treat those who have advanced untreatable neuromuscular disease, such as ALS or end-stage MS, requiring assistance with activities of daily living, or who require chronic ventilator support. So all of these folks who fell into these categories were per se going to be taken to the back of the line if they needed to be treated, and there was medical rationing at that time. So a lot of these policies were popping up all over the country and were very discriminatory against people with disabilities. And the intersection that came from this is, okay, people with disabilities and who's most impacted: Black and brown people, queer people, people who are low income. So these are two of the bad actors whose policies have since changed. But I think to understand why we even got here, we have to look at our culture. And so, when I was studying this stuff about a year ago, when I was writing an article, I found all of these incredible quotes and thoughts of these politicians and other people as to why medical rationing and people with disabilities and the elderly should basically be forgotten during COVID. Here's our buddy, the Texas Lieutenant Governor, Dan Patrick. He said, you know what, I'm an old guy. I'm sure senior citizens, he said, would rather die than let COVID harm the economy. So let's just sacrifice ourselves, older people. So that's what he was saying, that the aging population really should sacrifice for the younger population. And then we have this guy, Ken. He's a former city planning commissioner of Antioch, California, and he thought it'd be a good idea to put on his Facebook page his belief about herd immunity. So he wrote, during COVID around, May 2020, we need to adapt to herd mentality. A herd gathers its ranks, he wrote. It allows the sick, the old, and the injured to meet its natural course in nature. All right, so I want to go back and say Dan Patrick's photo, he's a gray hair guy in his 50s, looks like a stereotypical politician with glasses on. So that's Lieutenant Governor Dan Patrick. I don't have a photo of the city planning guy, but he really essentially is saying, if you're old, you're injured, and you're sick, let COVID take you, and the rest of us, survival of the fittest. And he lost his job for that statement that he posted on Facebook. Another disturbing sort of cultural and societal and medical pronouncement during the middle of COVID was from the Journal of the American Medical Association. I was really surprised reading this. This was in March 2020. And when they were talking about medical rationing policies, they said, well, you know what, we should really look at the number of years that we're going to save by providing, life-sustaining treatment. So, and JAMA, the Journal of American Medical Association, wrote, and these are all scientists and medical folks, quote, the moral intuition of many people, and they're saying this is what society wants. We should support prioritizing a patient who might lose 40 years of life, as opposed to somebody who maybe has a chronic illness who might die within a couple of years. So rather than go out and say, we should basically not let people who are chronically ill or people with disabilities, just not receive treatment, they framed it such as this. And this is the Journal of the American Medical Association sort of, confirming that it's okay to let the aging, the chronically ill, people with disabilities to not receive life-sustaining treatments because the younger or the more healthy, per se, should receive it. So this is the culture and the politics that we're living in still now at this time. And then, of course, we have the Supreme Court. So they had a couple cases during COVID, and at the time, a lot of prisons and jails had to contend with their population and those who are immunocompromised, and deciding, well, do I have to change things? Do I have to provide masks? Do I have to implement new health policies to ensure that those who are incarcerated do not get sick? And then in April 20, and I believe this was August 2020, the Supreme Court rejected the implementation of safety measures at the Orange County Jail. Now, these safety measures would have protected about 3,000 pretrial detainees and incarcerated people, 488 of whom were medically vulnerable, and would have protected them from COVID had these safety measures been implemented. But the Supreme Court said, no, Orange County, California, you don't have to do that. And in a scathing dissent, Justice Sotomayor said, this is absolutely, not the right decision. It's very clear that we could prove that respondents could prove that the jail is being deliberately indifferent to the health and safety of inmates, and they're violating federal disability rights law. So that was Sotomayor saying, you know what, you're violating disability rights law, and it is deliberately indifferent potentially for you not to implement safety measures to protect those who are medically vulnerable. And let's think about who is in prisons and jails. We're really talking about Black and brown people. So I think when you look, and I like this slide because it really kind of puts in context sort of the culture that we're living in, from state officials to local officials like this Ken guy in Antioch, California, to a medical association, to the Supreme Court. All of these different levels of power are saying people with disabilities, people who are chronically ill, people who might not have that many years of life to live should go to the end of the line when it comes to life-sustaining treatment during COVID. And so I wanted to also provide some context of what this really looked like in numbers, right? So we've got this societal acquiescence and political acquiescence and judicial acquiescence to discrimination. But what does that look like? So coronavirus in color. So we learned as the pandemic ravaged certain communities, what communities were most impacted. So for the Black American population, and if you think about this in context, and the latest stats are March 2021. So I don't know, I'm sure somewhere there's more stats available, but at this time, 1 in 555 Black Americans have died of COVID. That's 1 in 555. So that means that Black Americans have experienced 4.9% of all deaths of known race, but Black folks only make up 12.4% of the population. And there's really no reason that should be happening, but we're going to talk about like why that's happening. And then the indigenous Americans have died at a disproportionate rates of 1 in 390. So that's 256 deaths per 100,000. And then a recent study, about a year ago, a study came out and said, okay, what about economics? Let's talk about that. So they did a study looking at, urban counties, and this is really, powerful statistic. And looking at 158 urban counties where the population was substantially non-white, but the income was around 60,000, the rate of COVID deaths was 9 times higher than compared with counties with the same exact median income that was white. So really, they had the same median income, Black, white, but then the deaths were 9 times higher. So why is that happening? Like race and COVID and medical rationing, disability, like what is going on here? And a couple other statistics I thought were really important is, looking at coronavirus and disability, and the bifurcation of the analysis is still there. So when you look at the pandemic, you see a lot about race, you see a lot about disability, but never the two shall meet. So it's very hard to find these statistics of the intersection of the virus and disability. So I thought these are really important for us to see. So in June 2020, and this is out in the medical rationing policy, the intersectional policy, this information is in there. And a lot of what I'm saying is actually in this medical rationing intersectional policy. So you can take a look at it. But in June 2020, autistic and intellectually disabled people in Pennsylvania were twice as likely to die from COVID, twice as likely. And these are independent studies that found these numbers. People with developmental disabilities in New York were 2.5 times as likely to die compared to COVID-19 patients without disabilities. And then developmental disabled persons between 18 and 74 had a death rate of nearly twice as that is the same age peers. So what we're seeing, coronavirus in color, okay, and disability, we're seeing disproportionate rates of people dying of COVID. All right, and so how did we get here? And so, as I said, the two intersections of race and disabilities were not discussed a lot when we were talking about COVID in 2020. And the dialogue has definitely shifted, both with disability rights groups and people who are talking about the narrative. But many of you might already know the story of Michael Hixson, who was in the paper. He was a Black man. He died of COVID, but what happened was he was in the hospital. He was with his wife of, I believe, 18 years. 46-year-old Black man, father of 5. He has multiple disabilities. He has quadriplegia, cortical blindness, and he had a brain injury. He actually contracted the virus from a nursing facility, which is a whole other webinar on terms of COVID and nursing facilities. So when he got into the hospital, he was given a guardianship over his wife's objection. So the state and the medical professionals made the decision as to what kind of treatment he should receive. And what happened was Melissa Hixson, the wife, recorded the doctor about, providing him life-sustaining treatment. And the doctor essentially said, well, he doesn't have much of a quality of life. And the wife said, well, why are you saying that? Are you saying that because he's paralyzed, because he has a brain injury, that he doesn't have a quality of life? And the doctor blankly says, yes, that's true. And the wife says, who gets to make the decisions about whether somebody's quality of life, if they have a disability, and whether they have a quality of life or not? And so the state and the doctor did not give Michael Hixson life-sustaining treatment, and he passed away. And this made the headlines, and there's a lawsuit against the hospital, but it's based on torts and not disability-based discrimination. But this was kind of the first really front page narrative you saw on the intersection of disability and race. So, and I thought that was pretty powerful. And I know we have a few more minutes, and I need to get into the history, so bear with me here. So really, how did we get here? I only have a couple of slides left. So how did we actually get here? We're talking about COVID, we're talking about who's most impacted, we're talking about race, disability, the high incidence of death. Well, this goes way back, and we have to look at history, we have to look at slavery, and we have to look at eugenics. And we have to look at a word called ableism, which is a word that is being used more and more to really identify like the systems in place to make inequality and systemic racism flourish. And I think this is a really nice definition by T.L. Lewis and Dustin Gibson. It's Dustin Gibson. Ableism is a system that places value on people's bodies and minds based on societally constructed ideas of normalcy, intelligence, excellence, and productivity. And these ideas are deeply rooted in anti-Blackness, eugenics, colonialism, and capitalism. So when you look back at slavery, when enslaved people were often returned because of their vices. Indeed, they were returned or they weren't accepted by the person who wanted to purchase them because of their disabilities, rheumatism, epilepsy. They were running away, and that was considered a disability. So there was this pathologizing of race and a disablement that was really rooted in slavery. And so when you look at slavery, it was really about productivity, and any kind of infirmity or any kind of power over your own autonomy, such as running away, was labeled a disability. And there was something called drapetomania that a pseudo doctor created to say, if a slave chooses to run away, they have a psychiatric illness called drapetomania, and therefore they're psychologically unfit, they're unsound. And the way that we can cure them from this mental illness is by giving them lashes. And so the idea of Blackness as disability, it was really ingrained during slavery in creating this idea of Blackness as inferior, Blackness as inadequate, dangerous, depraved, criminal. And that sort of sense of depravity and criminality of Blackness has really carried through time. And here's a picture of a Black woman who's kneeling on a medical table surrounded by white doctors. And this is just a history of medical racism. So here you have a doctor, his name was, let me make sure I got the name right, Marion Sims. He was a famous gynecologist, and he performed surgeries on Black women without any anesthesia and cut through their genitalias. And he was the father of gynecology, right? And at the time in the 1900s, and still today, there's a sense that Black people are impervious to pain, that they can tolerate a tremendous amount of pain threshold. Here we have eugenics, the idea that we have to make a superior stock of people and then get rid of inferiority. And so you have this Black persons as impervious to pain, as depraved, have mentally ill. Then you have the idea that we need to rid the world of those who are inferior, and that's eugenics. And here you have a picture of two women sitting together. One is younger, one is older, and this is Carrie and Emma Buck. And it's as if so in 1927, the Supreme Court sort of validated the idea of eugenics and said, you know what, states have the right to involuntarily sterilize women who are institutionalized. And that kind of created this sense of okayness, that it's okay to sterilize and dehumanize people because of their lack of productivity, or they're considered feeble-minded. And here's a picture of some Black men, and this is probably a picture from the mid-1900s or so, and it's about the Tuskegee Study. And this study was, the state sanctioned the study of Black men who some had syphilis and some didn't, and did experiments and said they were treating these Black men when they really weren't treating them. And this went on for 41 years, where the state condoned experimenting on Black people and not giving them treatment because they wanted to know the effects of syphilis. So we have this whole history of eugenics, of slavery, where people who weren't deemed as productive, who weren't deemed as normal or intelligent, were essentially sterilized. They were beaten. They were thought of as less than. And this is where the idea of medical racism really evolved, and its roots are there. So who's historically most impacted in the healthcare settings is Black, Indigenous, people of color, people of higher weight, older adults, and queer folks. They are impacted by the negative biases, inaccurate assumptions of their quality of life, capacity to communicate, and their likelihood of survival. So I just want to zip through this, but so to understand examples of medical racism is, for example, providing less pain management for Black people, because in society there's this belief based in incorrect history that Black people are impervious to pain. But there's a study of people in medical school who still believe that that is to be true. And for people who are Hispanic whites, which is the language used in this study, is that they weren't readily admitted to the emergency department because there's a belief that they're actually, we're going to turn them away because they actually don't need medical assistance. And so this is an awesome, disability justice advocate named Alice Wong, who did a quote, said, "Eugenics isn't a relic from World War II. It's alive today, embedded in our culture, our policies, our practices. It's imperative that experts and decision makers include and collaborate with communities disproportionately impacted by systemic medical racism, ageism, and ableism." I'm going to wrap up in a second. So this is my last slide, and there was a rally by White Coats for Black Lives Matter. So here's a picture of a Black doctor with a mask on and a white coat. He's holding a brown sign that says, "Systemic racism is a public health crisis. Hashtag White Coats for," and there's no language, but it should probably say Black Lives. And this slide reads, "Discrimination and structural racism are key contributors to inequity in health behaviors and outcomes." So racial disparities in health resulted in decades of systemic inequities, hundreds of decades is like an understatement, hundreds of years of lack of access to healthcare, education, employment, and housing. And just like one intersection, like employment, more than 80% of people with disabilities are unemployed. And this is a Bureau of Labor Statistics. Housing, LGBTQ youth of color, 40% experience homelessness. So who's being most impacted? And so this is an example. So that's the end of my presentation. Sorry it took a little bit longer. Thank you.
Thank you, Natalie. That was amazing. And I am so happy that we had you on. I think it was worth having that extra time because it was so, this a really comprehensive overview. I'm going to hand it over to Shira, who will give us a overview of our work on crisis standards of care and other forms of medical discrimination and the legal and advocacy community response.
Thanks, Sam, and thanks, Natalie. That was a really great background and context to set up for this discussion, which, as Sam mentioned, is really kind of, I guess, getting a little bit more into the weeds on some of the complaints that we filed over the course of the pandemic on discriminatory crisis standards of care and other policies relating to medical care for people with disabilities. So starting at the beginning, back in March 2020, in the early stages of COVID spread in the US, it became clear that the country may become overwhelmed by the pandemic and hospitals could reach capacity and begin having to ration medical care. And this really set off alarm bells in the disability community that people with disabilities would be first to be denied access to care, given a long history of experiencing discrimination in medical care. And Natalie has really helpfully provided some background where you can understand why something like this would set off those alarm bells, and justifiably. So to start with and kind of thinking through how to address this challenge and these fears, we developed some basic guiding principles in collaboration with ASAN and other national disability rights groups back in March. And when I say March now, I mean March 2020. A lot of time has somehow passed since then. And those principles were developed to guide the advocacy work that we were going to do moving forward around crisis standards. So some of those basic guiding principles include that the lives of people with disabilities are equally worthy and valuable, that people with disabilities must have equal opportunity to receive life-sustaining treatment, stereotypes and judgments about the quality of life of people with disabilities have no place in treatment decisions. To avoid discrimination, doctors must perform a thorough individualized review of each patient and not assume a disability diagnosis is determinative of a prognosis. And also, and this is something Natalie also touched on, that federal disability rights laws broadly protect people with disabilities against discrimination in receiving medical treatment. So beginning in March 2020, the ARC and others, so we worked with state and national partners, including ASAN, to challenge disability discrimination in medical care during COVID. And over the course of the pandemic up till today, we filed 14 complaints with the US Department of Health and Human Services Office for Civil Rights, or OCR in short. challenging states' discriminatory crisis standard of care plans and hospital no visitor policies and inaccessible COVID-19 testing sites. And so I have a brief description here. I think we already talked about what crisis standards of care plan are. So I don't think we need to discuss that. So we can kind of jump ahead to what some of the complaints included specifically. So while each crisis standard presented somewhat different issues, there were several categories of issues that discriminated on the basis of disability that we saw in most of the plans that we challenged. And so here I have kind of a bunch of examples of the types of categorical issues that we saw in these plans. So one is categorical exclusions based on disability diagnosis. So for example, identifying those with intellectual disability or cystic fibrosis as ineligible or deprioritized for treatment just based on their disabilities. Exclusions from treatment based on assumptions regarding greater time or resources required for recovery or projected lifespan. So for example, assuming that someone with Down syndrome will not live as long as someone without Down syndrome or may require additional resources to treat and denying care on that basis. A failure to modify triage assessment tools to avoid penalizing people with disabilities. So for example, these kind of tools might assign points based on certain characteristics, such as ability to speak or move in certain ways that some with disabilities are unable to do, having nothing to do with COVID and whether they can benefit from treatment. Some plans allowed for reallocation of personal ventilators to another patient deemed more likely to benefit from treatment, which meant that for those with disabilities who used a personal ventilator in their daily lives, having nothing to do with COVID, some plans allowed these to be reallocated to those deemed more likely to benefit from treatment under these assessment tools. And another factor that we saw was a disproportionate impact on Black, Native, and Latinx communities who experience greater COVID-19 infection and hospitalization and may have greater occurrences of underlying conditions and shorter lifespans. So many of the crisis standard of care plan complaints also address the issue of hospital visitation within those broader complaints, but we also brought some complaints that were specifically challenging no visitor policies as a standalone issue. And these policies were put in place in hospitals around the country at the beginning of the pandemic to try to prevent COVID spread by restricting access to the hospital to anyone who is not a patient. And so while those restrictions were to some extent reasonable given the dangers of COVID spread, and especially in the beginning when not much was known about how COVID spread, regardless, any policy has to provide for reasonable accommodations for people with disabilities to ensure that the policy does not deny them equal access to care. And in the original state that they were in, a lot of these no visitor policies discriminated against people with disabilities by denying patients effective communication, depriving patients of the right to make informed decisions and provide informed consent, causing patients to be subjected to use of unnecessary physical and chemical restraints, overall leading to a denial of adequate and necessary medical care because patients were not able to communicate, and also potentially subjecting patients to lasting emotional harm for being in a traumatic situation and not being able to communicate with their medical personnel as needed. In addition to those complaints, we also filed a complaint against the state of Nebraska for failure to accommodate people with disabilities in its statewide COVID-19 testing program by requiring the ability to access and use the internet to complete pre-screening and the ability to drive to a testing site, which are things that many with disabilities, particularly those living in congregate settings, as well as those experiencing socioeconomic barriers, do not have access to. The pre-screening site also presented barriers to those who are blind. So that's a bit of an overview of the complaints that we filed. And now I'm just going to talk a bit about some of the results that we saw from that. So since March 2020, when we filed our first complaint, we had some significant and relatively quick successes in achieving changes. Within a week of filing our first complaint against the state of Washington, OCR issued a bulletin, and that's the Health and Human Services Office for Civil Rights, outlining the prohibition against disability discrimination in medical care during COVID-19. And I'm just going to read a short excerpt from that bulletin, which said, "In this time of emergency, the laudable goal of providing care quickly and efficiently must be guided by the fundamental principles of fairness, equality, and compassion that animate our civil rights laws. This is particularly true with respect to the treatment of persons with disabilities during medical emergencies, as they possess the same dignity and worth as everyone else." So I just thought that was important to actually read from the bulletin, because that's something that really gets to the point, makes the point very well and succinctly, and really guided a lot of the work and how we framed it to states and hospitals. So in response specifically to the 14 complaints that we filed that I just talked about, OCR worked with these states and advocates like the ARC and ASAN to reach favorable resolutions in a number of states and hospital systems. And so some highlights from the resolutions include, and I'll talk about Alabama, which Natalie mentioned earlier, had a particularly egregious language in its original plan, and Alabama withdrew that plan which had that offensive language and replaced it with another plan. That was one of the earliest victories. Connecticut and MedStar Health, which is a DC hospital system, revised their hospital no visitor policies to allow designated people to visit any patient with disabilities that requires support, and to provide them with personal protective equipment as needed so that they could visit safely. And then the other complaints that had to do with more broadly with challenging crisis standards of care, so that included Tennessee, Utah, North Carolina, Arizona, and regional health agencies in Texas, revised a number of aspects of their policies, including removing all categorical exclusions based on disability or resource intensity, eliminating long-term survivability as a consideration in treatment decisions, requiring reasonable modifications for triage assessment tools and no visitor policies, prohibiting the reallocation of personal ventilators to other patients, and requiring hospitals to provide information on the full scope of available treatment alternatives, including the continued provision of life-sustaining treatment, and prohibiting blanket do not resuscitate policies. So that's a bit of an overview of some of the complaints and the resolutions that we got throughout the last year and a half at this point. And there was also a lot of media coverage of these issues. I can put a page in the chat that kind of compiles we have links to all the complaints, many articles that have been done on this topic. And the media coverage also, I think, really had an impact on some of these positive outcomes too, and getting the word out about these issues. So that sums it up at this point, and I think we're gonna talk about some additional questions about work for the future.
Hi, everyone. Thank you so much, Shira. I forgot to make this announcement at the beginning of the webinar, but late is better than never. So everyone, if you have questions for our panelists, if you need someone to explain something that didn't make sense when they were talking about it, or if you need people to slow down, please either raise your hand or make a comment in chat in order to have us read your comment to our panelists. So let's talk a little bit about how the complaint process has worked. Shira, can you give a sense of what your experience was participating in some of these complaints and what we have learned over the course of the past year and a half?
Yeah, so let's see. It was a huge team effort. This really was something where the disability community, I think, mobilized really quickly on these issues. And again, I think Natalie's background that she gave was really helpful in understanding why this was such an issue of immediate urgency. And so I think there were a number of us, from national organizations that then worked with local either affiliates or local organizations. So, the ARC and ASAN and National Disability Rights Network, Center for Public Representation, Bazelon Center. So the ARC has chapters across the country, NDRN has the Protection and Advocacy Network. And so it was really a collaboration between so many of these different groups. I think it's also important to mention that there was also collaboration between even organizations that were not necessarily identified as disability specific organizations, but for example, the organization Justice and Aging was very active in these complaints because of the overlap between older adults and people with disabilities. And so we worked together as well, and racial justice organizations. And so there was a lot of collaboration. And at a certain point, we also worked on, like I mentioned earlier, there was a lot of overlap in the issues that we were seeing. So once we did one complaint, and we were seeing a lot of common issues, I think it became a little bit easier to put different things together after that. And we also put together an evaluation framework for the general public to use that basically made it kind of highlighted these common issues that we were seeing and boiled it down to those common categories. And so even though there were differences, of course, between all these different plans, there was also a lot of similarities that we were able to highlight and helped us move more quickly on certain issues.
Thank you, Shira. And I want to move to Natalie too, because she was, when we were preparing for this webinar, she was talking about how her researchers sort of have been monitoring how these complaints have evolved over the past year, and sort of changes between the first complaint and later complaints as well.
Yeah, thanks, Sam. I was going to mention that. So, as Shira said, it's pretty impressive how all the disability rights communities and other organizations really came quickly and coalesced to address this and start filing complaints against the states. And so, a while ago, I had my research assistant kind of do a deep dive into a bunch of complaints, and I had her identify where the complaints identified, people of color, communities of color, any kind of intersectional language. And there seemed to be a pretty strong trajectory. And I think this is probably due in part to how quickly disability groups had to move, but there was not a very strong sort of intersectional inclusion of language in the early disability complaints. Like, for example, in March, Disability Washington, there's no sort of discussion about race or age, or, Alabama in March 2020, Tennessee, March 2020. But then if you move on to around May or so of 2020, so that's pretty quickly that I think the disability groups started kind of getting it together. There was much stronger language as to who is being most impacted by these medical rationing policies. And there were a couple standouts. Disability Rights Oregon did an excellent job talking about the immigrant community, communities of color. I think in part, I noticed that there was, and Shira mentioned that other non-disability groups also got together, which I think is so important in disability organizing, cross-movement building. And it looks like in this Oregon complaint, there's a coalition of communities of color, that's the name, Coalition of Communities of Color. That's an alliance of culturally specific communities based in Oregon that highlighted communities of color: African, African American, Asian, Latino, Middle East, North African, Native American, Pacific Islander, and Slavic. And so as you started sort of looking at how these complaints, not all of them, how they were developing over time, there was much more of an analysis of, okay, state, recognize this history, recognize the systems in place, recognize that there's more poverty in this community and that community. And because of that, there's going to be medical racism, and these, not just people of color, but that intersection of disability, people of color, low income, the Native community, these are folks that are being impacted. So you could really see that shift And I actually think this is a real education, and this is a complete personal opinion. I feel this is a real education for the disability community. I mean, disability rights folks, when they're approaching this pandemic and this crisis, that cross movement mobilizing was so critical, so that the message is broader, because COVID is not a single issue struggle. It impacts so many at the intersection. So I do give such credit to the disability rights community in terms of embracing that and kind of learning and growing as these complaints were built and navigated around it in such difficult circumstances.
One thing that I thought was really interesting when we were working on complaints around crisis standards of care is the extent to which there was the limitations of discrimination complaints in this context. So there was a push to challenge standards that either explicitly singled out disability or were singling out medical conditions that might not necessarily impact a person's immediate survival ability. But even if you had a perfect triage, and by perfect I mean by the standards that states were trying to use, which was to save the most lives, right? You're still going to have disparities that disproportionately affect older people, disproportionately affect people of color, and disproportionately affect people with disabilities because of those health disparities that make it more likely that people will come to the emergency room sicker. And so what can we think about in terms of more proactive approaches that go beyond just crisis standards of care and try and rethink how, rethink the system that got us to the point where we had crisis standards of care? Either
I think one
you
thing
can answer that.
one thing to think about is just that, like, right, everything at the point of when you're talking about crisis standards of care, when they actually might be implemented, is an urgent thing, right? And so I think in terms of being forward looking, it's about taking a step back and saying, what did we learn from this experience, and how can we think about working with the medical personnel, medical schools, et cetera, medical ethicists, to kind of think about these issues when it's not a pandemic and when it's not urgent, and when rationing care isn't potentially happening or around the corner from happening. And so I think, we've seen a lot come out during COVID. There was a study showing, I don't remember the percentage, but a significant percentage of doctors, had, whether it was conscious or unconscious bias against, people with disabilities, and making judgments about their quality of life. That was something that came out in Health Affairs. I think there's a lot of different work that can be done both around training and thinking through some of these prioritization issues, but also just these larger issues of training and making sure that the medical establishment, which involves ethicists, physicians, nurses, and things like that, are educated about people with disabilities and the rights of people with disabilities when it's not a crisis. Because once it's a crisis, then everybody's scrambling. And one challenge with the way that crisis standards of care in particular work is that it's totally a patchwork system. And so there's no like federal crisis standards of care. So, the fact that not only was it urgent and of course a life or death kind of situation, but we're also scrambling to figure out what are the state, is it a state level crisis standard? Is a hospital level? Some states didn't have anything. And so there's so much that I think could be thought of when we do have the luxury of taking a step back. How do we make the system more comprehensive, and how do we make it safer for people with disabilities, and that has a lot of steps back from being too close to discrimination, and how do we make it a more comprehensive system and standard, so that we're not just scrambling when it is a more urgent situation. Hopefully we don't have another pandemic anytime soon, but it is, it does teach you a lot about what you don't even know and what's out there.
Yeah, I totally agree. And I guess maybe I have a more, not pessimistic, but we have to undo hundreds of years of medical racism and the pathologizing of race and the disabling, of people who, are disabled or poor. And I think it's a true culture and knowledge shift. And so this goes back to cross movement building. I mean, I think absolutely, like I went back before this panel to kind of reread, how medical students view Black and white people differently in their level of pain threshold. And that's still taught in medical school. So we're graduating students who become doctors who still believe in people with disabilities don't have as good a quality of life. And that's sort of, they're indoctrinated with that knowledge in medical school. So I think, it's taking a huge step back and starting from the root of where, what's going on in education. And I think that requires, and I'm sure that work is being done. I'm sure people are on it, but I think it has to be, you have to take this giant step back and really unroot like the culture that's embedded in the racial disparities and access to healthcare and health treatment.
Let's talk, I'm realizing that we've spent a little bit more time talking about crisis standards of care, and I want to talk also a little bit about access to supports and communication supports in hospitals, because we were seeing, and frankly, in many other settings, because we were also seeing this happening in institutional settings, where people, hospitals and institutions started dramatically restricting who could come in and out of the setting, especially members of the public. And people who use communication supports, emotional supports, or cognitive supports in order to access healthcare or go about their daily lives if they were living in these settings, were suddenly cut off from those supports and not able to bring supporters in with them. Shira, can you talk a little bit about the process of challenging those policies?
Yeah, so, that was especially concerning because, when we're thinking only on the policy, basically it's just so concerning because the fact not being able to have visitors made it even harder for us to know what's happening on the ground, especially if it's with someone who needs communication support and needs someone who knows them and is able to help them communicate. They might not be able to tell someone else what, have a cry for help or tell someone what's happening. So it's just a very worrisome situation. Of course, regardless of whether someone needs communication support, this whole, all of these issues in general combined are very concerning because they happen behind closed doors, even if there is a visitor there, right? I mean, or we would call it more of an assist, or the policies were called no visitor policies. But really someone who's helping, assisting a person with a disability to have effective communication is really not a visitor. They're somebody who is assisting that person and is completely vital to be there. So, that was really one of the most common issues where we got direct complaints from family members, caregivers, assistants, etc., that were saying we're not able to access, we're not able to help this person who's in need of support communicate. And so it was really something that we focused on. We had 2 complaints that were just about those issues because some hospitals or states had standalone policies on those issues, but all of our crisis standards of care, complaint, and resolutions that I mentioned also resolved visitor policies and required reasonable modifications to visitor or no visitor policies, because that was just such a critical thing. I mean, you can't access medical care if you don't have the supports you need to communicate effectively with the people who are treating you. And of course, there's only more room for stereotypes and bias and assumptions to seep in if you don't have the support you need to communicate effectively. So that was a big priority of us throughout, and it was really addressed both in separate complaints and resolutions, but also the broader complaints and resolutions that we brought.
Do we have any questions from the audience? I've been looking at chat. I don't see any additional ones, but I'm just trying to see if I'm missing any. Let me see if anyone's got their hand up. All right, I'm just gonna let you both give final parting thoughts, and then we will say goodbye to everyone.
Sure, you want to start us off?
You know, I think that this was, while it was, I mean, this whole year and a half has been a tragic experience, and there's been so much loss of life, and there's been a lot of evidence of discrimination. We also did make strides in kind of recognizing it, hopefully preventing it, getting really critical policies modified, and really coming together as a disability community and intersectionally with other communities to address the deep-rooted issues here. And so I think, I guess to close, I think something that Natalie has also already said is that we really need to continue to work together in these ways and use the relationships that have been built and all the knowledge that we've gotten. We knew there was discrimination in medical care, but I think a lot of things have come to light, you know, on a more specific level from this experience in both racial disparities, disability disparities, and ways in which these communities can work together to address the discrimination and disparities, and hopefully take a step back from the time of crisis and urgency to think about how can we train medical personnel, how can we continue to work together to try to prevent the type of crisis that we had during COVID. And so I guess I hope that we can continue to move forward on that, and that we don't forget the lessons that we learned, you know, as we were working on all of these issues throughout the pandemic, which is still happening, but hopefully we're moving forward to another day on that.
I echo everything Shira said. And on top of that, I would say, you know, I think just historically, you know, as disability advocates, we've really sort of stayed in our lane. And I do think that this presented a very emergency opportunity to get out of our lane and communicate with others in the community on an issue that we all could really, you know, we're really struggling under in an emergency. And my hope is that we, you know, as disability advocates, that we take this and jump and use it when we do housing advocacy, criminal justice advocacy, LGBTQ advocacy, and that disability is a part of all of these tenets of different people's lives. And you know, I think about this a lot, and I'm starting to write about it more. And as I run my own legal clinic, thinking about how I could be more intentional in my disability rights advocacy, so it's not so single issue. And that, so my takeaway from the pandemic and how disability rights advocates came together is that this is just hopefully the beginning of what our disability rights future is going to look like, with more diversity in terms of issues, and coming together and working to sort of really challenge the systemic issues and not just, you know, disability rights and integration. And so that's my hope for the sort of future and what we've learned from this experience.
Thank you so much. I am going to read a couple of comments from the chat, and then I will thank our presenters, and we will close the session for today. Eleanor Wildflower says, thank you for the webinar. It was very informative. And Curtis Harris says, Medicare for All, aka single payer, will eliminate health disparities for people with disabilities. Everyone in, nobody out. Thank you so much, Professor Chin, Shira Wakschlag, for this amazing webinar. I am so grateful for your time and expertise, and I hope that everyone learned something today. Have a
Thanks
great
for having
day,
us.
everyone.
Thanks. That was really great. Thank you, everybody. Take care.
Bye.
Thank you.
Bye.
Bye-bye.